Hello and welcome to this Clinical Care Options Infectious Disease podcast. I'm your host, Robin Black. This episode features content from an educational online module titled RSV in Older Adults, Epidemiology and Risk Factors. During this podcast, Dr. Dexter Wiseman, Clinical Research Fellow at the NHLI Imperial College London and HS Doctor at the Royal Brompton Hospital in London, discusses RSV in older adults, including epidemiology, seasonality, the impact in care homes and hospitals, and the effects of the COVID-19 pandemic on RSV infection rates. For more information about Dr. Wiseman and for a link to the full online educational program, including downloadable slides, please visit the link in the show notes for this episode. Now let's get started and hear what Dr. Wiseman has to say about RSV in older adults.
Hello and welcome. My name's Dexter Wiseman. I'm a Clinical Research Fellow at the NHLI Imperial College London and an NHS Doctor at the Royal Brompton Hospital in London. I've been researching RSV for a number of years, focusing on older adults and those with comorbidities. Thank you very much for taking the time to watch this pre-recorded lecture, which will be one of three. This presentation is going to be regarding risk of severe outcomes for RSV in older adults. The learning points from this talk will be: what is RSV? We will look briefly at the structure, when it was discovered, and how its effects alter throughout life. RSV epidemiology, how prevalent is it, focusing on the EU but also looking across the rest of the world. Seasonality of RSV, when is it most commonly found? RSV outbreaks, looking at RSV in care homes and hospital settings. And RSV in a post-COVID world, is this still relevant? RSV is an enveloped negative sense RNA virus. It was initially discovered in 1956 by researchers in a chimpanzee, and then discovered the following year in children with respiratory illnesses. RSV replicates in the respiratory tract, which results in primarily respiratory symptoms. The virus enters the airway through the nose or mouth. It infects initially mainly the ciliated cells, then moves down into the lower airway. Viral replication is more effective in the lower airways, and this has been demonstrated in both infant and animal studies. Viral titers in sputum samples have also been calculated to be higher than in nasal samples. This lower airway replication propensity could explain why older adults with chronic lung conditions such as COPD appear to be so affected by RSV. We will discuss this in more detail in Talk 2. The term older adults is somewhat non-specific. It usually refers to adults over 65 or over 60. The EMA guidelines for RSV studies define older adults as those over 60 years old. Most medical professionals still think of RSV mainly as an infant virus. This image very concisely depicts the impact that RSV has throughout life. For infants, RSV is the primary cause of hospitalization, and it is responsible for many primary care encounters every season. From young childhood until older adulthood, RSV doesn't appear to cause as much of a burden amongst healthy individuals, although it has been found to trigger asthma and COPD exacerbations. This is very much an understudied age group when it comes to RSV disease. In older adults, RSV again becomes a major pathogen, causing hospitalizations and death. The reason for this is multifactorial and likely due to a combination of the presence of underlying comorbidities, such as chronic cardiac or pulmonary disease, immunosuppression, or diabetes, the physical aging of the lung, and the aging of the immune system, or immune senescence, with the decline of the Th1 and innate immune responses, as depicted at the bottom of this slide. Published in 2021 by the Utrecht Group and Korsten, this excellent study investigated the burden of respiratory syncytial virus infection in community-dwelling older adults in Europe. The study recruited 1,040 participants who were aged from 60 to 100 with a median age of 75 from 3 sites in Europe, Antwerp, Oxford and Utrecht, and across 2 seasons. Serology was taken at the first study visit. Therefore, this could serve as a baseline for diagnostic serological testing using antibody titer rises. As discussed in the next talk, a serology rise is often needed for diagnosis of RSV-related events. During the study period, if any participant suffered from a cough, nasal congestion or discharge, wheezing or shortness of breath for 1 day or more, then they would come in for sampling by the study team within 72 hours. RSV illness, which was based either on PCR diagnosis or the 4-fold serology rise in RSV-specific antibodies, was diagnosed in 59 of those 1,040 participants. That's 5.67% in the first season and 4.2% in the second. No participants were hospitalized or died from RSV illness during the study. This highlights the importance of investigating RSV in the community and not only focusing on hospital admissions. The symptom duration averaged 19 days, and a doctor's visit took place in 11 of these 36 cases. This highlights the burden of disease even if admission to hospital is not required. Again, in this study, RSV illness could not clinically be differentiated from other acute respiratory tract infections based on symptoms alone. Similar studies to this have shown an annual incidence of RSV ranging from 1.6 to 7% annually. Differences could be based on diagnostics. Analysis of UK data estimates that in adults over the age of 18 years old, there were over 487,000 GP encounters and nearly 18,000 hospitalizations and 8,500 deaths attributable to RSV per season. Of these, 36% of GP episodes and 79% of hospitalizations and 93% of deaths were in those over 65 years of age. How about RSV rates across the rest of the world? In 2020, there has been a global meta-analysis investigating the burden of RSV as it was in the year 2015. The authors of this study reviewed studies from 1996 to 2018 and applied the data to populations as they were in 2015. The studies included 16 with hospital-based admission data and 9 with community-collected data. RSV acute respiratory infections for adults in industrial countries were estimated to be 6.7 cases per 1,000 persons per year. The authors estimated a total of 1.5 million cases of RSV acute respiratory infection in industrialized countries in 2015, with 214,000 of these cases involving hospital admission. There was unfortunately such limited data from developing countries that they couldn't complete this part of the analysis. The annual incidence has recently been estimated to be from 19 to 25 per 10,000 population in the USA over 65 years old in another meta-analysis. There are currently estimated to be around 54 million adults in the USA over 65. This would equate to 100,000 to 130,000 RSV-related respiratory infections in the USA alone. Seasonality of RSV. The RSV season in Europe and the USA is mainly from October to February. This usually lasts between 16 to 18 weeks in Europe. The seasonality in Europe and the USA does alter slightly country by country, as per shown in the graph. There is a slight variation seen when comparing different states in the United States with different climates. Looking again at the graph, this shows the RSV season across different European countries from the 2016 to 2019 seasons. The last peak is the 2020 going into 2021 season. This peak is delayed and the incidence is lower. This is probably due to the COVID-19 pandemic, and we will discuss the impact of the COVID pandemic on RSV rates later in this talk. This animation really nicely depicts RSV seasonality globally through the year. We'll start at October, when RSV season starts in the Northern Hemisphere, and as you can see, over the year, the prevalence of RSV decreases in the Northern Hemisphere and then starts to increase in the Southern Hemisphere during their winter. Note how similar the RSV season is to the influenza season. RSV in care home settings. RSV is growing in prominence as a significant pathogen amongst care home residents, with annual incidence rates amongst residents estimated to be 5 to 10%. 10 to 20% of these cases result in pneumonia, and 2 to 5% of these cases are estimated to be fatal in this population. RSV is an infectious disease, and there are case reports of it spreading throughout healthcare institutions. I've selected a case report looking at an RSV outbreak in a long-term care facility. Here, PCR was used for diagnosis. 22 of 52 residents became symptomatic in a 1-month period, and 7 of those 22 patients were tested PCR positive for RSV. Interestingly, none of these became positive on rapid antigen testing, and the reason for the rapid antigen testing being negative in older adults is thought to do with the viral load being lower than it is in infants. The diagram on the left a schematic of the nursing home showing these positive cases. With diagnosis being difficult, some of the other 22 cases may well have been RSV cases. 2 of the 7 cases were hospitalized and 1 of the 7 died. In a separate 15-month study, as shown at the table, RSV-associated respiratory viral infection occurred in 10% of 165 care home attendees. As you can see, RSV was the most common pathogen amongst the elderly residents, but it was also found amongst the staff as well. As mentioned at the beginning of this talk, healthy young adults can catch RSV, but this is a very understudied population. Now moving on to look at hospital admissions. In England, RSV was estimated to account for an annual average of 71 respiratory admissions per 100,000 adults aged 65 to 74, and 251 admissions per 100,000 adults aged 75 and over. The median hospital length of stay, as averaged over 5 European countries in a separate analysis, was 12 days for adults over the age of 65 and 8 days for those under 65. Hospitalization rates for RSV are similar to that of strep pneumonia and influenza. In the USA, it's estimated that 177,000 hospitalizations amongst adults over 65 years or older are caused by RSV, and 14,000 deaths amongst adults over the age of 65 are caused by RSV. The annual mortality rate for RSV amongst older adults eclipses that of infants by over 20-fold, with an estimated 500 infants dying of RSV annually and 14,000 older adults. Discussing the mortality for RSV in a little more detail, amongst hospitalized adults over the age of 60 who tested positive for RSV between January 2011 and June 2015 were identified from an area in Southern California. Over this time, 644 adults over the age of 60 were hospitalized with RSV. Approximately half had radiologically confirmed pneumonia, and 21% required ventilator support. There was a documented 30-day, 3-month, 6-month, and 1-year mortality of 8.6%, 12.3%, 17.2%, and 25.8% respectively. The graph on the right just indicates how much of a factor age is in regarding mortality from RSV. Those with advanced age, defined here as over 75, had a 68% survival rate compared to 84% survival rate amongst those aged 60 to 74 years old. Comorbidities are also a major factor in poor outcomes, but I talk more about comorbidities in the next presentation. Is RSV still relevant now COVID-19 is the virus of the year? Well, RSV's not died out. There was a noticeable drop in infections during lockdowns in Western Europe and in the USA, but this process is now reversing. But there has been a surge post-lockdown in many states and territories. The graph at the top right of the screen shows RSV seasonality in the USA since COVID-19. What's interesting here is to note that during the lockdowns and with face mask mandates and increasing hand washing, RSV rates were very low. There will be multiple reasons for this. Post-lockdown, however, RSV has recovered quite quickly, as can be seen on the lower graph of the two. Also, what is noted is that influenza has appeared to take a little longer to re-establish itself. Australia noticed a decrease in the variety of RSV variants, and the seasonality of RSV is not following the usual pattern this winter. The graph at the bottom of the screen shows percentage of positive tests for RSV after the lockdown easing in New South Wales, and the marked uptick in RSV positivity after this. It must be noted that neither of these studies differentiate the cases between patient age groups, but it is evident that RSV is becoming present in the community again. So in summary, RSV affects people throughout their life. The burden of disease is greatest at the extremes of age. The seasonality of RSV is that it usually occurs mainly in the winter months. RSV causes significant hospitalizations and mortality. RSV has not gone away post-COVID. And care home studies and COVID precautions highlight the need for possibility of suppressing the virus. Effective vaccine would greatly aid in this endeavor.
Thank you very much to Dr. Wiseman, and thank you to our listeners for joining in. As a reminder, to view the full program, click on the link in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.